All right, let's go ahead and get started. Good afternoon, everyone. My name is Hamira Osman. I'm the VP of Research and Public Policy at Muscular Dystrophy Canada. We are thrilled to have Dr. Duquette here today to talk about Friedreich Ataxia. And this is part of our Let's Talk NMD, Let's Talk Neuromuscular Disorders webinar series. It's in recognition of the upcoming Friedreich Ataxia Awareness Day. And so this webinar should have been available in English and in French. Unfortunately, our interpreter just let us know that they won't be available to provide simultaneous live interpretation. However, the recording of today's webinar will be available in English and in French on our MDC YouTube channel by next week. So we will follow up with the links to that. Dr. Duquette is here today. He has earned his medical degree and a master's degree in neurological sciences from the University of Montreal in Canada. He subsequently completed a residency in neurology and a fellowship in movement disorders at McGill University in Montreal. He continued his training with a postdoctoral fellowship at the Brigham and Women's Hospital in Boston and a research fellowship at Harvard Medical School. He is a past recipient of the Clinician Scientist Training Award from CIHR, the Canadian Institutes of Health Research. Currently, he is an associate clinical professor and an adult neurologist in Montreal. He is a fellow of the Royal College of Physicians of Canada and a member of the Movement Disorder Society, Progressive Supranuclear Palsy and Rare Movement Disorder Study Groups. And he is a member of the Collaborative Clinical Research Network in Friedreich Ataxia. He's also one of the principal investigators for the clinical outcomes measure in Friedreich Ataxia study, and also a principal investigator, so a key researcher for the MOVE-FA clinical trial. He has published dozens of articles and abstracts and has served as a principal investigator or sub-investigator for over a dozen clinical trials. We're really pleased to have you today to talk about clinical and research updates, and over to you.
Thank you very much. You hear me well? Yeah. Thank you for this introduction. So as you said, I'm an adult neurologist in Montreal, and I care for a very large number of Friedreich ataxia patients. Here we go. So this is the SHIM, the brand new hospital where I do most of the research work. But most of our patients are actually, I see them at this rehab center called Centre d'Adaptation Lucie Bruno, sorry, where I'm fortunate to have an excellent multidisciplinary team to do patient management with me. So I'll just zoom in on ataxias. I'm sure a lot of you are very familiar with what ataxias are, but they're a large family of diseases that affect the nervous system, and there are several causes of ataxia. What they all have in common is a lack of motor coordination. And there are several types of ataxias and several patients who are probably members of Muscular Dystrophy Canada can have sensory ataxias, which are coordination problems that increase, especially when with eyes closed. However, when we talk about ataxias, we generally mean cerebellar ataxias. And it gives rise to these symptoms. Hopefully the videos will work. Will they?
On one side, just as fast as you can. And tap on the other side. And hold your arms like this. And just flex up the elbows. No. Yeah, just like this. There you go. And I want you to just take one wrist and just rotate it back and forth.
So we see the irregular movements that are a characteristic of ataxia.
The other side again.
And that's in the upper limbs, but it also affects gait. And this particular patient does not have FA, but another hereditary ataxia. And we see the wide-based gait that is a characteristic of ataxia. So these are two important clinical manifestations of ataxia. And as I said, when we talk about ataxia, we often mean cerebellar ataxias. So what's the cerebellum? In Latin, it's the little brain. And what's fascinating actually is that even though it only represents 10% of brain volume, it actually represents 50% of total brain neurons. So it is very a key structure in the brain that people certainly don't talk about enough. And it has several functions. The ones that were the more obvious ones and the more obvious functions that we associate with the cerebellum are the motor functions, where it's important to maintain balance and posture, for the coordination of voluntary movements. These are the videos I showed you. And it's very important for motor learning. We know that, the cerebellum is very active during sleep. And as research progresses, we realize that it plays a significant role in several cognitive functions. So the cerebellum sits right here underneath the posterior portion of the brain. What are causes of ataxia? Well, there are hundreds of causes, genetic and non-genetic, and these causes vary a lot according to the age of so I see someone asking comment mettre en français. On me dit qu'il va y avoir une traduction qui va être disponible plus tard, mais que malheureusement la traduction n'est pas disponible maintenant. And I'll be happy, donc ça me fera plaisir de répondre aux questions en français. I'll be happy to answer questions in both English or French towards the end. So the various, there are various causes of ataxias that vary according to the age at which symptoms appear. And very often, as is often the case with genetic diseases, autosomal recessive diseases tend to start earlier, and autosomal dominant diseases tend to start later. But especially in adults, there are, beyond genetic causes, there are tens of causes of ataxia. It can go from autoimmune diseases such as multiple sclerosis, to stroke, to cancer, to alcohol toxicity. We won't discuss those today, but there are really hundreds of causes of ataxias. The most common genetic causes of ataxia, these also, they vary a lot depending on where we are in the world. Typically, the most common hereditary ataxia is Friedreich's. However, it is quite rare in certain areas of the world, sub-Saharan Africa, Southeast Asia, and other forms of ataxias are more frequent in certain areas of the world. So you can see a sample of what the most common causes of ataxia are in different parts of the world. Here in Canada, FA probably is indeed the most common one. So what is Friedreich ataxia? The disease was described in 1863 by Nicholas Friedreich. And it was actually the very first ataxia that was distinguished from other ataxias. And it is a disease, as I said, I think I said previously, it has an autosomal recessive inheritance. So parents are usually unaffected, but carry a disease-causing variant in one copy of the frataxin gene. And, statistically, 1 in 4 children of 2 parents who are carriers will develop the disease. The prevalence, it varies worldwide. Estimates vary from 1 in 20,000 to 1 in 50,000 individuals. And people, so we can estimate the number of affected individuals to be between 750 and 1,900 people in Canada. However, the 1900 seems to be a tad high because there are estimates that there might be about 15,000 affected people worldwide. So I'd be surprised if we were close to 1900 in Canada, but the 750 certainly is possible. What are the symptoms and signs of FA? The typical age of onset is between the ages of 5 and 15. So that's typical onset, but up to 15% of patients actually have their first symptoms after the age of 25. And before the era of genetic testing, these people would never have been diagnosed with FA because onset had to be before the age of 25. And there are several clinical features. Here we see a physician taking deep tendon reflexes in a child. Some features that are seen early are walking difficulties, slurred speech, increased muscle tone, which we call spasticity, scoliosis, which can be seen even before the onset of symptoms, muscle weakness, which is usually something that's progressive, loss of sensation, which can be found early, not necessarily something that patients or children will complain about, but when we formally test for it, usually position sense and vibration perception are decreased. And we usually find a loss of deep tendon reflexes. So that's why it's something that's considered so important, the examination of children who have ataxia. And usually, as disease progresses, some symptoms will add to these early symptoms, signs and symptoms. Not everyone will develop all of these symptoms, but these can happen. So palpitations, shortness of breath, usually a sign of heart disease, anywhere from glucose intolerance to full-fledged diabetes, hearing loss, vision loss, swallowing difficulties. These are all things that can happen as the disease progresses, but happens to a minority of individuals. And what are the causes of FA? As I said, it's an autosomal recessive hereditary ataxia. It has a very peculiar genetic mechanism. So one genetic mechanism for genetic diseases is triplet repeat or nuclear expansion, repeat expansion. Some other neuromuscular diseases can be caused by these, such as myotonic dystrophy, type 1, OPMD, oculopharyngeal muscular dystrophy. But several ataxias are caused by these repeat expansion. The model disease is usually considered to be Huntington's disease, where a triplet, a C8G triplet is expanded and causes an accumulation of glutamine, which is toxic to cells. And most of these diseases have an autosomal dominant transmission, whereas FA has an autosomal recessive transmission. So parents have to be, as I said earlier, have to be carriers on one copy, but usually have another copy that functions normally and are unaffected. And when this GAA repeat, which is not in a coding sequence, but in an intron, a non-coding sequence, is expanded, it actually decreases the transcription, so the production of the frataxin protein, and this leads to disease. As I said, most people have this triplet expansion, but a minority, 4%, are actually heterozygous and carry one expansion on one gene, on one copy, and have a point variant, disease-causing variant on the other copy. And what's the role of frataxin? Actually, frataxin sits in or is encoded in the nuclear genome, but is transferred to mitochondria, where its function is not completely elucidated, but we think it helps assemble iron and sulfur clusters in mitochondria. And mitochondria are key parts of the cell because that's where most of the energy that powers biochemical reactions in the cell is produced. So the energy is produced there. And how's FA diagnosed? Usually it's through the clinical evaluation. The formal diagnosis I'll come to in a second, but usually people get a very strong suspicion because of the clinical presentation. There have been several studies looking at how the disease presents itself initially. The most frequent initial feature, gait or coordination disturbance. I chose one recent paper that looked at the several hundred European patients. In that study, the median age at onset was 13. So as I said, the typical onset is before the age of 15. But there are some features that can predate ataxia, such as scoliosis or heart disease. It's obviously a minority of patients, usually less than 10%. But if an orthopedic surgeon or a pediatric cardiologist are especially vigilant, they're able to suspect a diagnosis even before there is any sign of ataxia. And once we have a disease-modifying drug, that will be key to be able to identify affected individuals very early on. And there are some suggestive features where if you have an ataxic child with absent reflexes, and we look at the eyes and we see what we call square wave jerks, which is different from a nystagmus. A nystagmus is the eye beating when you look in one direction or another, whereas a square wave jerk is just an ocular movement when an individual looks at something, and everyone who's familiar with or knows an FA patient has seen these movements. So when we see that in someone with ataxia, it's highly suggestive of FA. Obviously, family history can be helpful. As I said, it's an autosomal recessive disease. So if we have any indication that the disease might have an autosomal dominant transmission, such as seeing 3 successive ataxic patients in 3 successive generations, for example, that makes it very unlikely to be FA. And often, so family history can be helpful, obviously, if you have 2 affected individuals in the same family and one already has a diagnosis. But very often, or if we have history of consanguinity when we do family history. However, very often, especially with the small number or the smaller families nowadays, very often there will be no family history at all of FA or other ataxias. Some additional tests may be ordered, and they used to be ordered much more frequently in the past, such as an electromyogram, EMG, or nerve conduction studies, and imaging, such as a CT scan or an MRI, but imaging is very, very often normal, especially early on in the disease. And with all that said, the median time to diagnosis in recent years has been around 2 years between the onset of symptoms and before a genetic diagnosis is made. Before the era of genetic testing, the genetic testing era, this delay was about 4 years. So there has been improvement. But as I said, once we have a disease-modifying treatment available, decreasing this delay before diagnosis as much as possible will be key. Are there, and there might be some atypical features in FA. So as I said, we used to, that was way before I started practicing, but there used to be very strict clinical criteria to be able to make a diagnosis of Friedreich's ataxia, such as an onset before the age of 25 and having, absent tendon reflexes. But since the advent of the genetic testing era, and that we were able to confirm a diagnosis through genetic testing, clinicians worldwide have realized that the phenotype, the clinical presentation of patients, is actually much, much larger than our initial idea of what it was. And now, we have patients who can have an onset. I have patients who've had their disease onset after the age of 60. And some patients will have very, very little ataxia, but will have severe spasticity in their lower limbs. Some patients will have retained their reflexes. So the clinical presentation of Friedreich's is actually much larger now that we're able to prove a diagnosis in using genetic tests. And this has also been the case in most genetic diseases, where we now realize that the phenotype is much wider than what we thought before. As I said, genetic testing confirms the diagnosis. It's a simple blood draw, very similar to all other genetic tests. What's particular with FA, however, is that since it's a triplet repeat expansion, traditional sequencing panels. So nowadays, when we order, it used to be that there were no genetic tests, but at the start of the genetic era, people would see a patient with ataxia and would order one first test for one disease, and then 3 months later, a second test for another disease, and 3 months later, another test for a third disease. And it would take years before we were, even if we knew the actual genetic cause, it could take years before we ended up figuring out what the actual genetic disease was. Now, with the advent of next generation sequencing and gene sequencing technology progress, we've now been able to use sequencing panels where we'll look at hundreds of genes simultaneously. However, the current genetic technology and things, algorithms are improving and the technology is improving, but one has to be very careful that the right test was ordered, because these expansions can be missed if they're not looked for specifically. So even if someone had a genetic panel for ataxia, and even if the frataxin gene was part of that panel, a GAA expansion, disease-causing or two disease-causing expansions can be missed. So the right test must be ordered, and it's very, very, very important. Now, how is FA different from other ataxias? Well, its clinical features is one thing that set it apart from other ataxias. We've talked about scoliosis. Because of because the peripheral nervous system is affected, several patients will actually have pes cavus, so foot deformities that we will see in some other ataxias associated with a polyneuropathy or a neuropathy, but not all ataxias. The heart is can be very affected in Friedreich's, which is not a feature seen in most other ataxias. Because I see questions popping up, and I'll try to address those at the end, and I'll talk about OMAV later. Diabetes, there's a fair number of patients who develop diabetes, but certainly it's rather a minority of patients. And as I said, hearing loss, optic atrophy, and these are features that are mostly associated with FA and not necessarily other ataxias. The genetic basis is also different. As I said, there are, you see in the CAG, these are, sorry for the French slide, but spinocerebellar ataxias here, these are the autosomal dominant. So it's a triplet repeat, but these are autosomal dominant. It's not, so there are some differences on the genetic front. And then there are all the other recessive ataxias. So I said there are some different features, but usually the clinical presentation, vitamin E deficiency can be very, very similar to Friedreich's, but can be tested for. And the other ones usually have features that distinguish them. Here in Quebec, one form that we see often is the Charlevoix-Saguenay ataxia, but usually the disease onset is much, much earlier. And children usually develop progressive spasticity very early on. Now, what about prognosis? As I said, the disease is a repeat expansion, and there is something particular with repeat expansions, and that has been very, very well characterized with the autosomal dominant diseases such as Huntington's, and this table is taken from data that was obtained in Huntington's, where you see this is the repeat in Huntington's. If the repeat length is 39, the median age at onset is 66, whereas if the repeat length is 50, the median age at onset is 27. So there is an inverse correlation between the size of these repeats, the length of this repeat, the CAG repeat, and the age at onset. So the longer the repeat, the earlier the disease starts. And this has been shown for several, very well for several diseases. And the same has been shown actually for Friedreich's. The difference being that the disease is an autosomal recessive disease. So we all carry 2 copies, and affected patients also carry 2 copies. So it's actually the size of the smaller repeat that is best correlated with age at onset. So, you know, prognosis can vary according to the exact size of the disease-causing variant, the exact size of the expansion. And this is important because age of onset has also been shown to be correlated with the rapidity or progression, the speed at which the disease progresses. So again, several studies have been done looking at that. This is one that has used the data from FACOMS, the study of which we're now part of. And here they divided patients with regards to, or according to the age at which the age of symptom onset. So if symptoms started before the age of 15, this is the dark blue. Between the ages, so they're considered typical. Between the age of 15 and 24, they're considered intermediate. And after the age of 24, they're considered to have a late onset. And you can see, so here it's not the age of the patients, but rather disease duration. And this line here represents the point at which half the patients in that group now use a wheelchair. So we call that loss of ambulation or wheelchair use. And you can see that in the early onset group, so the patients for whom the disease started before the age of 15, they usually use, half of them will use the wheelchair regularly about 12 years after disease onset. Whereas the later, when the later start usually is 23 to 24 years after disease onset. So we see that the disease tends to progress more quickly in patients whose onset was earlier. Now, whether this really correlates with other symptoms such as heart disease In heart disease, there is certainly a correlation. So this was taken from the European cohort again, and they were able to figure out that there was the vast majority of patients had stable heart function when they were followed for 11 years, up to 11 years. But there was about a fifth of patients who actually had decreased heart function as time went on. And these patients, that's what I've highlighted here. And when you look at the group with the decreased left ventricular function, the expansion size tended to be slightly larger. So they weren't able to correlate it with neurological disease severity, but amongst the ones who had a progressive heart disease or more severe heart disease, the expansion size for the short allele tended to be larger. People have looked at that for diabetes and other clinical manifestation. It doesn't seem to always hold true. And it's not necessarily that someone had an early onset that they will develop heart disease, but there's a trend or a significant trend that amongst those who will have heart disease, the expansion tends to be a little bit larger. So it's hard to really give a general prognosis for everyone. It really has to be individualized for a given patient. Now, what are the treatment options for FA? And what about supportive treatments for FA? The core, and as I said, I follow most of the FA patients I see in a rehab center because really the multi or interdisciplinary team is at the heart of our management. PT, OT, social work, speech therapy, nutrition, kinesiology, because they have a gym there, and exercise. This really is at the heart of our management plan. Ortheses often decided with PT, and then we have maximal medical management of various issues: heart disease, diabetes. Very often we'll manage spasticity with baclofen. If someone requires very high amount, can go to a baclofen pump. Several patients, I don't do the injections myself, but several patients will receive toxin injections for significant spasticity. Scoliosis, patients can have bracing or surgery. It's quite rare that since I'm an adult neurologist, usually patients have had surgery before I see them, if they were to have surgery, because it usually occurs after growth spurt, but before transitioning to adult care. When patients have bladder dysfunction, we have antispasmodic agents. If we suspect sleep apnea and we can confirm sleep apnea, it can be treated with a CPAP. For patients, so some patients have hearing loss, but a lot of our patients have what we call a divided attention problem. And a divided attention problem is that, hearing can be decreased a little bit, but hearing is decreased significantly when there is a distracting noise around. So, and I had one patient who was telling me this week that he can't use a public phone where he lives because there's just too much noise around and he can't hear anything. But if he were, when we were talking one-on-one, or if he was in a calm environment, he could use the phone. So in those cases, we can use support measures with a microphone and a receiver, because traditional hearing aids are often not as helpful, and psychological support when required. So this really is the basis of our management. Unfortunately, at this time, we don't have any disease-modifying drugs, and here's where OMAV comes in. Omavaloxolone might become the first disease-modifying drug available for FA. The mechanism, we won't enter into too much detail, but it works on activating one important mitochondrial factor, and its principle is protection of the mitochondria and reactivating mitochondrial function. And there was a phase 2 trial, which started in January 2015 and was completed in October 2019 with 172 participants across 11 sites worldwide, 7 of which were in the US, 1 in Austria, 1 in Australia, 1 in Italy, and 1 in the UK. And you'll notice that there were no sites in Canada. So when that study took place, I did not have the relationship I now have with FARA and the whole North American and CCRN consortium that I now have. So hopefully we will avoid situations like this where Canada is kind of left out in trials. But that trial, so on the right is the paper that was published in October 2020 with the results, and you'll see in panel A down here, the left one at the bottom, where you see what's interesting, but it's a very good illustration of the placebo effect. So when the curves go down, patients actually improve. So both the placebo group and the OMAV group improved at 12 weeks, so about 3 months. But then afterwards, you see separation between, so it's on mFARS, the clinical scales that use a modified Friedreich Ataxia rating scale. And we see that after 1 year, there is a significant difference, and the rate of separation between the two curves actually increase at 1 year, but the data stopped at 1 year. Now, based on that data, Reata, the company that makes OMAV or wants to commercialize it, actually submitted new drug application to the FDA or had a pre-NDA meeting, and the FDA, unfortunately, in the US told them, you lack data. So they've asked them to provide additional data. They've provided additional data because these participants were actually followed for longer, so they had additional data to show. But the FDA was still not convinced, and they said, "Well, no, you probably have to do another trial." Obviously, Reata were not pleased about that, and FARA, the Friedreich Ataxia Research Alliance in the U.S., started a petition, obtained more than 74,000 signatures, as well as a support letter from clinicians, and I signed that letter to support the further development or that to encourage the FDA to reconsider their decision. So in September, Reata, the company, had another meeting with the FDA, and that was a positive meeting because they said, well, you can now consider doing a new drug application in early 2022. And they said, well, but you'll still need to submit new results, but that can happen later. And you'll see, because they'll need to do studies in the pediatric population also. So in November 2021, the FDA gave them a fast track designation, which allows for certain technical different ways of applying for marketing and for approval. And in March 2022, so a few weeks ago, Reata actually did a rolling submission for a new drug application. The rolling submission means they don't have to send, because usually companies will have to submit a complete package to the FDA, and the rolling submission allows them to submit the package bit by bit. And at this time, and it's public because I found it online, they expect to launch in the US in early 2023. Now, and to answer the question that was raised, what does this mean for Canada? Even though I wasn't involved in the trial, I have been in contact with the company, obviously, because we certainly have an interest. Whenever I speak with them, however, and you can imagine how these things are very strictly regulated, especially because these are publicly traded companies. So very often, and we can't actually learn stuff before it is publicly available. So I don't have any additional information. I've asked repeatedly and I always get the same answer: we can't tell you. So I know that their efforts were focused on the FDA because the market's so much larger in the US. And they were also focusing, because in Europe, the European Medication Agency, or anyways, I don't know how to say it, l'Agence Européenne du Médicament, deals with, for most countries, and the population size, the FA population size is probably similar to that of the US. So that was their other priority. So I suspect Canada will be a priority, because they've encouraged exchange between myself and them, but I don't have any further information as to what that means. But we'll obviously fight for it to be available once it is commercially available. And I just wanted to show the eligibility criteria, because even if the product becomes available, another fight, so there is one with Health Canada, another fight is with actually the payers in Canada, which could be private insurance or the provincial governments. And we, since the study was done in individuals between the ages of 16 and 40, and the modified FARS score was between 20 and 80, we don't know whether that will have an impact on if it does indeed become available, whether payers will decide to pay for individuals that are outside that range. I'd be surprised if it were available for children before any trial is done in children. But for example, for individuals that are older than 40, or individuals who have a mFARS score above 80. So usually 80 is close to the cutoff point where people are non-ambulatory. So when people use a wheelchair daily, so we might have to fight a little bit to extend the indication. Hopefully it won't be too restrictive. So, but we're obviously waiting for news as to whether this will come to Canada also. But if it were approved in the US, it would certainly help a lot. And I just wanted to mention that because that's part of the work we're doing right now, is that there are several challenges with hereditary ataxia clinical trials. One is common to all rare diseases, is that there are a limited number of patients, and this has two. The impact is on two fronts. One, obviously, we will never be able to do a trial with 40,000 participants like they do in cardiology, and they'll be able to see tiny statistically significant differences, maybe not clinically meaningful, but certainly statistically significant differences. So that has probably hindered the development or the approval of some drugs. The other thing is there, and you'll see in a second, and many of you are probably aware of the FA development pipeline, but there are several products, which is great, several products that are in development. But speaking with people at FARA, they anticipate that there actually won't be enough patients to participate in all the trials that are coming because there are so many of them. So that's certainly one challenge. And another one is that progression happens over several years, and the year-to-year progression is not huge on our clinical measures, which means that to see change, and change that could possibly be projected over several years to certainly clinically, delaying the loss of ambulation or several very, very clinically meaningful things, because the progression is over several years. Clinical trials are very, very costly for companies who want to bring a product to market. So they can't do, and I'll talk about the MOVE-FA trial that we're doing right now, which takes place over a year and a half, even 2 years with a built-in extension. This is an exceedingly long trial. Usually, like the MOXIE trial, they're usually over 1 year. And companies can't do trials over 3 or 5 years. That would be way too costly for them. And they want to have an answer over a year or two. And because the progression is not huge over a year or two, this makes it hard to measure change or meaningful change in that over that period. The clinical presentation can be variable. That can be a challenge, especially for FA. The clinical evolution needs to be better characterized, which has improved over past years because of the natural history studies. And the clinical measures we use, they lack sensitivities measured change. You're all used to seeing, a neurologist do a neurological exam and say, well, tap like this and like this. But that doesn't change much over a year or two. And we need to have better tools to measure with more precision and some precision that we can actually project to, over 2 or 3 or 5 years. If we see this difference over 1 year, this means that kind of difference over 5 years without doing the actual trial over 5 years. And there was this question as to, is there research being done on FA in Canada? And as I said, until recently, so actually not much. It had been a while since there was a clinical trial done in FA in Canada. That probably goes back to the days of Katina Idebenone, nearly 15 years ago. But I've been fortunate enough to join this consortium, of which Grace Yoon, whom some of you may know in Toronto, was already part of. So there are now 13 sites in that consortium, 8 in the US, 2 in Canada, 1 in Australia, 1 in India, and 1 in New Zealand. The objective is to collect data. So it's really the FA-COMS, Natural History Study, stands for Friedreich Ataxia Clinical Outcome Measure Study. And it's built like a clinical trial, but rather than seeing people every 3 months and doing the standardized evaluation every 3 months, we do it yearly. And instead of having an investigational product, there is no actual product that is given, but we're able to follow disease progression over several years. We've started we have some participants who've done their 3rd visit, I think, but some data goes back to 2000 or 2001, because some of those sites in the US, there were 4 or 5 initially. And they have upwards of 1,000 participants now. So it's to better understand disease progression, develop and validate new outcome measures, help with the design and implementation of clinical trials, and to make them more efficient and effective, and also collect biological samples to study biomarkers. At this time at SHUM, we have 37 participants. And we will have, under the SHUM umbrella, starting in 2022, we'll have sites, satellite sites at Saint-Justin and at McGill with Dr. Fournier at Saint-Justin, who's a pediatric cardiologist, and Dr. Pandolfo, who is very famous for discovering the frataxin gene as responsible for FA. So he just moved back to Montreal a few months ago. And there is already a pediatric site in Toronto with Grace soon. But Grace has not participated in clinical trials, has decided not to participate in clinical trials. So that's that. So that's for FA-COMS, our natural history study. And that's the current pipeline as kept by the Friedreich Ataxia Research Alliance. And you see here, OMAV is the one that's at the level of NDA application that has been filed. The other one who's the most advanced is PTC 743. Minarix has completed its phase 2 study, will probably start a phase 3 study, but it has yet to be published. And there are several exciting developments with gene therapy, CRISPR, and all that. So the most advanced one being Lexeo Therapeutics. So hopefully we'll be part of some of those trials as these move forward. And obviously not all of these will pan out, but it's very exciting to see that there are several trials that are coming. I want to say a word, and I see time is flying, on the MOVE-FA clinical trial with PTC Therapeutics. So we were very happy to be able to offer the first FA clinical trial in Canada in more than 10 years since Katina. The product is called vatiquinone. It started in December 2020. It's a phase 2b/3 trial. Recruitment was completed in September 2021, and there is a total of 146 participants. There are sites in 9 countries, 5 in the US, 2 in Canada, the 2 being CHUM, where I work as I am the principal investigator. And there is also a site at Saint-Justin where I do the neurological evaluations, but Dr. Fournier is the principal investigator. At CHUM, we have 18 participants, which makes us the 2nd largest site worldwide. For those who know, researchers in the FA world, the number 1 site is CHOP in Philadelphia with Dr. Lynch, who's very, very prolific and follows a very large number, but we're the 2nd largest site worldwide. So we were very happy about that. At CHUM, we see participants ages 14 and up, and we were also very happy to have participants from 5 provinces: Quebec, Alberta, Saskatchewan, Ontario, and New Brunswick. And there are 5 participants between the ages of 7 and 13 who are followed at Saint-Justin, including 1 from Alberta. And the scheduled end of study is April 2023. So hopefully we'll have interesting results shortly after that. And I had something about us developing tools in virtual reality to measure upper limb function, but I think I'll just leave some time for questions, because that was the very last or nearly last thing. Just want to take a second, because if any of you are parents or thinking of having children, I collaborate with Evelina, who's actually a PhD student, an occupational therapist and PhD candidate who works on having a physical or motor deficit and taking care of children. So there will be a webinar on May 31st on that topic. It will be in French, but if anyone is interested, you're more than welcome to register. All right. So hopefully we have a few minutes for questions.
This is great. We have 5 minutes for questions. I really appreciate a really insightful and clear talk. Thank you for addressing all those key questions that came straight from the community for today. One question, and then we'll go to the Q&A that I see in the chat here, is: are there predictors for how FA will progress over the course of childhood and adolescence? So is there something that can be seen in a biomarker or in a genetic testing, is what they're asking, in terms of telling you when there can be a loss of ambulation, or when that typically will occur? So they're looking.
Yeah, no, we can't really predict that. As I said, the one element obviously is age at onset. So the earlier an earlier age at onset is associated with typically a quicker progression. But that's pretty much what we have. We don't have very good biomarkers. Obviously, a lot of people are working on identifying biomarkers and ways to predict disease progression or identify people who could be candidate for certain interventions once we have disease modifying interventions, but that is work that remains to be done.
Another question here is, do you know of any countries or any places that do newborn screening for FA?
At this time, no. But that I don't know. I don't think there is. And, you know, sitting on international panels, but I've been around more people from Australia and the US, Brazil, India. I don't think any are doing newborn screening, but this will certainly become a very, very hot topic once there is gene therapy or we have very good disease modifying drugs.
The individual who asked that question said the reason why they ask is they wish they knew earlier because they had a misdiagnosis a few times before FA was given to them by their neurologist.
Yeah.
Here's a question. I think you mentioned it, but it was, are certain regions in Canada, are there certain regions rather where FA is more prevalent?
Yeah, we actually know. So the prevalence varies in different ethnic groups. Actually, in Quebec and in the French Canadian population, the carrier rate is a little bit higher than other regions of the world. So I'd probably say that it's slightly higher in Quebec and the French Canadian population.
Very good. There is a question here in French, but as I roughly translate it here, it is that if an individual is over the age of 50, are they now not open to clinical trials or research opportunities?
It varies. No, so we're happy for the natural history study. We're very happy to welcome individuals who you know, at any age. And for clinical trials, it really varies from trial to trial. So I gave the example of eligibility criteria for MOXIe, where they topped out at 40, but for the MOVE-FA, the vatiquinone trial with PTC, there was no upper limit. There was a restricted number of individuals above the age of 21, but we have one participant who's 66, I think. But they had to meet other criteria. So for that trial, they had to be ambulatory, so they were able to walk. So that gentleman was able to walk, but you know, there was no upper age limit.
Excellent. I know you've answered some the questions already about the drugs, but how about the question about CRISPR?
Yep, that's a very good question. CRISPR. Very good, but complex. So our major issue at this time is vectors, because we have to deliver, you know, the CRISPR machinery, and the same actually applies to gene therapy, just for gene replacement. And our vectors at this time are not very good at penetrating the central nervous system. So the successes that we're seeing for spinal muscular atrophy, for example, you know, we're really targeting the spinal cord, and there are some that, you know, you can have a very localized treatment for, you know, for the eye, or gene therapy for some, you know, blood disorders where you can actually give a treatment to cells outside the body and give them again. But, you know, we can't take the brain or the cerebellum out to treat it. So we need to have vectors that will reach their targets. And that is actually the big challenge at this time. We don't have very good vectors, and there will be various strategies that will be used. Some will target other parts, or, you know, there might be some trials that will target only the heart. There might be some trials that will do intracerebral injections, but that tells us that the vectors are not very good at reaching the central nervous system. So we'll have to cross that hurdle before CRISPR becomes a reality for the disease.
That is excellent. So I know we're at time. So with that, I want to thank you. Many of those in the chat are commenting to saying you're such an expert and that they wish they can share this webinar with their own physicians. So yes, please do so. I know, again, I just want to end off on the note, Muscular Dystrophy Canada, while our name includes muscular dystrophy, we surely include Canadians affected by FA. So we will also be in touch with many of you about research opportunities and hopefully clinical trial opportunities in the coming months and hopefully years as well. A lot of potential and hope here. So with that said, thank you again. Thank you for your expertise and a really great talk, and hope everyone has a good rest of their afternoon.
And I'll be happy to answer questions if people want to reach out directly.
That would be great. Yes. And you're always welcome to email research@muscle.ca, and we can always forward that along to you or connect with you on answers as well. Thanks, everyone. Have a good rest of your day.
Bye-bye.